Good morning, everyone. I'm very delighted to be a part of this very exciting event in Turin. Today, my task is presenting the efforts of Italian researchers in understanding and treating MRONJ, which is a story long 20 years. Very briefly, I'm a full professor in oral diseases, past president and current member of the National Board of the Italian Society of Oral Pathology and Medicine, who endorsed this event. This is my disclosure of no conflict. And for this talk, some days ago, I looked for ONJ PubMed from the start of the international interest for these novel diseases. In 20 years, more than 4,000 of papers have been published. The first case report and case series, as you know, were published in 2003, but only in 2007 the first position paper was published by the American Association of Oral Maxillofacial Surgeons, followed by a second one in 2009, again by the same American association. Since then, some Italian researchers, like me, felt the need to carefully consider the issue of the definition, and in 2012 we proposed a different definition, inclusive of cases without bone exposure and without the strict limitation by IOMS of waiting 8 weeks for a definitive but only clinical diagnosis. And in support of our theory, we published several cases of non-exposed ONJ. In the meantime, a new issue arose for everybody. First, cases of osteonecrosis non-biphosphonates related and associated with denosumab and/or new molecules with anti-angiogenic action. That's why our scientific societies decide to change the name of the disease from MRONJ, biphosphonates related, to MRONJ, medication-related osteonecrosis. Of course, the name changes, but the definition and the adjudication case pathway did not change, either for them on the left, AIOMS, or for us on the right as Italian researchers. Essentially, a clinical pathway for AIOMS and differently a clinical radiological pathway for us. On the left, there are the doubts by IOMS about the use of radiographic imaging for the adjudication case process. In the middle, there is our letter to editor supporting our diagnostic pathway as a logical combination of drug history, clinical science, pain, and first and second level imaging that you can see on the right side. In our opinion, this workup is an efficient method to diagnose both cases of MRONJ with and without bone exposure. As explained in our recent position paper, the differences between the two groups of research can be explained by the chances of two different diagnostic models. On the left, the pattern recognition model adopted by IOMS is fast, based only on the clinical science but potentially misleading. The other model by Italian groups is analytical with the study of different findings, both clinical and radiological ones, probably slower but with the possibility to reduce the risk of a late diagnosis or even of misdiagnosis. Of course, everyone agrees on the diagnosis in a case like this one, anti-resorptive history plus bone exposure for everybody means MRONJ, but without imaging it is not possible to establish the real extension of this disease. The present case, according to IOMS, is not yet MRONJ, while according to Italian societies it is already an extensive MRONJ. In this case, analytical method is required to formulate a correct diagnosis, avoiding a diagnostic delay. Another big issue is the staging system. IOMS wanted to apply fast clinical thinking also to the staging system, while the Italian societies based their staging system on the deterministic radiological features. We can observe how, in these two cases, stage 0 for AIOMS, their stage is 1 and 2, respectively, according to Italian societies. Only the advanced picture, that is stage 3, corresponds in both classifications. And in our opinion, second-level imaging is essential to define correctly the disease. Since now it is clear that surgery is a real therapeutical approach, it is very important to know exactly the dimensional severity of MRONJ before making a decision process. Change issue. A novelty was born in 2023 from the Italian researcher group. We proposed stratifying patients at risk of MRONJ in 4 different categories, considering 2 different types of cancer patients based on dosing of bone-modifying agents, high versus low doses. Finally, we also introduced the category of patients with germ cell tumors of bone at high risk since they receive BMA, that is denosumab, at high doses. In a recent multicenter study conducted by us, breast cancer patients taking low-dose BMA for CTB prevention developed MRONJ. They are at a low risk of MRONJ, similarly to osteometabolic patients. We highlight the importance of including this category of patients in prevention programs, since they can develop in the next future bone metastases, switching to high-dose BMA treatments. Finally, also on behalf of my dear and many colleagues, I can say that we are very proud to present what we have made as a service to our communities of all health professionals and patients as well. In these 20 years, we have produced in Italy 9% of the world's results on MRONJ on PubMed. Now let's take this short touristic tour through Italy, starting from Sicily. I work with these passionate people in the sector of oral medicine at the University Hospital of Palermo. In 2007, we built up the Center of Research and Prevention of MRONJ, delivering several dedicated protocols in Italian language. Passing through the University of Messina, I introduced Giacomo Terri and his group. In Catanzaro, Amerigo Giudice and co-workers. In Bari, Professor Favia with his group. In Foggia, Professor Lomuzio and co-workers. In Naples, 2 groups, Professor Colella and Professor Mignonia. From the south to the middle of Italy, Sapienza University, Rome, Professor Umberto Romeo and his group of research. Pisa in Tuscany, Bologna, Parma, Alessandria Hospital with the great Vittorio Fusco, Padua with Alberto Bedonia and his group of research, University of Trieste with Matteo Biasotto and his co-worker, University of Milan, University of Turin with 2 groups of research. Of course, I apologize to you if I forget some Italian researchers and Italian universities. Multicentric cooperation in Italy and with the main European Research Center was crucial for us to propose the new definition and adjudication case method for MRONJ. Not only by means of a scientific paper, but also through dialogues during scientific conferences, usually planned and organized by Vittorio Fusco in Alessandria and now today in Turin. We organize also national training courses in collaboration with the Italian Dentist Registry Commission, international scientific webinar like this one with Italian and foreign speakers. And Coming back in Italy, we are making, as Italian researcher, a project with the Italian Agency for the Drugs, AIFA, on MRONJ and adverse drug reaction in general in dentistry in terms of pharmacovigilance, attitude and numbers. A very great project. And just yesterday, in the same hall, we discussed the new perspectives and digital methods to improve awareness and pharmacovigilance for MRONJ and several adverse drug reactions in dentistry. In conclusion, MRONJ is remain a multidimensional disease with, at least in my opinion, 7 different clinical issues. And for this reason, I think it's very important to stay tuned. Thank you for your attention and thank you to all people who permitted us to make this Congress today. Enjoy it.